Welcome to AETCM. Today we're going to discuss a case about a 21-year-old female who came to our ER with complaints of bilateral upper limb and lower limb spots over the past 3 days. So on initial assessment, patient was conscious oriented and coming to airway was patent, no secretions were noted. And in breathing, air entry was bilaterally equal, respiratory rate of 18 per minute and saturation of 99% in room air. In circulation, BP of 100 over 60 mmHg was noted and pulse rate of 92 per minute. In disability, GCS score was E4 V5 M6 with pupil bilateral 2 mm equally reactive. In exposure part, temperature, she was afebrile and pressure was covered to prevent hypothermia. And coming to secondary survey, sir, there was she has no allergic history and she was not on any comorbidities, no medications. She was not on any medications. The history was not.
What medication history you want to take?
She any antibiotics, sulfonamides, or any quinidines, like that.
You are dealing with the case of Peripheral. What are the drugs you want to roll out?
Antiplatelet, anticoagulants, any drugs interacting with the coagulation pathway.
Especially heparin. Okay.
Patient noted reddish small spots in bilateral upper limb and lower limb, more over lower limb than upper limb since the past 3 days. There was no history of any bleeding manifestation from the patient, and there was no history of any abdominal pain, fever, myalgia, back pain.
Which condition you get abdominal pain with rashes, lower limb rashes?
Abdominal pain. HSP.
Inaction in Peripheral. The patient can have lower limb rashes with abdominal pain.
And there was no history of any drug intake. There's no history of any melena or hematemesis also. And there was no any history of any bleeding manifestation in the family also, sir. In general examination,
no history of pregnancy. No history of pregnancy.
No history of pregnancy. That is very important. It's a female patient.
Periods.
Which condition you get pregnancy-related rashes like this? Which all conditions you can have thrombocytopenic rashes in pregnancy? Sarah has told one important condition. What is it? HELP syndrome. HELP syndrome, DIC, and somebody is having ITP and which is not dormant. Suddenly during pregnancy it can come up. SLE, which may not be visible. During pregnancy, it can flare up. So you have to be very careful. Pregnancy history is also very important.
And also regarding the RH, positive or negative, if she's a pregnant lady, that also very important.
She's a opposite.
No, when you are thinking of going for transfusions, components.
And her periods was 2 days back. No increase in periods were noted. General examination, she was thin built, moderately nourished lady. There was no history of any pallor icterus, clubbing, and edema. Lymphadenopathy was noted, bilateral cervical lymphadenopathy, more on the right greater than left.
If this patient had a young patient who is having cervical lymphadenopathy and rashes all over the body, what is the first differential diagnosis you tell? 20 years old lady coming with cervical lymphadenopathy, rashes all over the body, what is the first differential diagnosis? What leading question you will ask to the patient? Infectious mononucleosis. What leading question you will ask to the patient? Whether some doctor has given amoxicillin or not.
During sore throat.
Okay. So that is important differential. 20-year-old female coming with cervical lymphadenopathy fever, it can be infectious mononucleosis. Normally, some doctor may start the patient on amoxicillin because she is having sore throat. If the patient develops rashes, then it is infectious mononucleosis. That doesn't mean that patient is allergic to penicillin. Okay, it is a diagnostic test for IMN, but we should never try. It was a diagnostic test previously.
So on examination, she was having subconjunctival hemorrhage over her right eye, eye also, sir, and petechial rashes are noted all over her upper and lower limbs. And pulse rate was 90 per minute with a respiration of 18 per minute, and saturation of 100%, and BP of 110 over 70 mmHg. On systemic examination, coming to GIT,
Any history of epistaxis
no sir, no
or any
history
other
of
bleeding prolonged period? Nothing.
no,
You see
sir.
the oral cavity,
Oral cavity.
Or yeah.
lips.
Yes, sir.
Petechial races also be there in the oral cavity. Mucous membrane.
Oral cavity was normal, sir. No
Normal,
history of any
okay.
bleeding. And
Hematuria.
No hematuria.
Okay.
Nasal also there was no bleeding history, no epistaxis history. And coming to systemic examination, there was no hepatosplenomegaly. Per abdomen was soft, non-tender. Other system
If
was
spleen is palpable, large spleen is there, what are the differential diagnoses? With thrombocytopenic purpura, spleen is palpable. Is it ITP?
CLD, hepatosplenomegaly.
Tell the difference because we are dealing this type of case in India. So, there is a first diagnosis. First diagnosis is malaria. Malaria is the most common thing where we have thrombocytopenia with splenomegaly. And malignancy, you have to rule out malignancy because lymphoma, all other hematological malignancies can have thrombocytopenia with splenomegaly. But first thing is always infection. Okay. Can it be ITP? It cannot be ITP. That is very important. If you are getting thrombocytopenia alone without any clinical feature, then it is ITP. If you are seeing any other clinical features, you have to think an alternative differential diagnosis. Okay.
And other systems are within normal limits. And we sent for the lab values. Lab values show total count of 5,000 with RBC of 3.5 lakhs and HB of 9.2. And platelet count was noted to 4,000 initially.
4,000.
Yeah.
This HB is normal?
HB is
Slightly low.
slightly
Okay.
low, sir.
Okay.
And later on, we also did a peripheral smear testing, and the result came to a microcytic hypochromic anemia with thrombocytopenia.
What platelet counts they opened in that count?
It was less than 10,000, less than 10,000.
What is the importance of platelet count in a peripheral smear and a automated machine, what we do routinely? What is the importance of both?
One thing is actually when we are doing with automated machines, sometimes clumping can be wrongly interpreted as thrombocytopenia.
Okay. So due to any reason clumping occurs, the machine will pick up it as only one. Maybe it may be 5 or 6. Okay. But peripheral smear exactly they tell what is a count. So whenever we have doubt, always take a peripheral smear. One is to count exactly what is a count. Second thing,
We can found any atypical blast cell in the
okay, other conditions we have to rule out like malaria or atypical cells like leukemia. All these things should be ruled out. Lymphoma, can you rule out with peripheral smear?
you can see blast cells and monoblock.
If there is blast cells, it is leukemia. There is no blast cells, it can be lymphoma. See, peripheral smear lymphoma ruling out is very difficult. There are some Rowley formation or abnormal cells can be there, but malignant cells cannot be, routinely cannot be there in lymphoma. That is the main difference between CLL and lymphoid leukemia and lymphoma. If there is no malignant cells in peripheral smear or bone marrow, only in lymph nodes it is lymphoma. If there is malignant cells in the peripheral smear, it is leukemia. There is a main difference. Okay.
Yeah, and later on, sir, we were on
So
the
you have thrombocytopenia.
Thrombocytopenia.
One problem.
Yeah.
What is another problem? She is having anemia.
anemia.
Did you rule out hemolytic anemia?
There was
You have only told it is microcytic hypochromic anemia. Mostly it is iron deficiency anemia. But did you rule out hemolytic anemia? If there is associated hemolytic anemia, what is the condition?
Bicytopenia.
It is Evans syndrome. Evans syndrome is hemolytic anemia, immune mediated hemolytic anemia with immune mediated thrombocytopenia. How do you know that it is immune mediated hemolytic anemia? You are not ruled out.
Coombs test.
Coombs test. Okay, so you can ask for a peripheral smear. that you have done that does not show any bite cells or fragmented cells, then you can ask for a Coombs test. If Coombs test is positive, then it is immune-mediated hemolytic anemia. If it is immune-mediated hemolytic anemia with thrombocytopenia, it has to be Evans syndrome. If only thrombocytopenia is there, the other one is due to some iron deficiency anemia, then it is immune-mediated thrombocytopenia alone. Okay.
Coombs test was done, sir. That's
It is
negative.
negative. So that is ruled out. So every test there is a reason why they are doing Coombs test. Because hematologists do it because they have to rule out immune-mediated hemolytic anemia. Then the treatment is different, not the treatment for ITP.
Following which we were having differential diagnosis of ITP at TTP also, sir.
At this juncture, did you do any bleeding profile?
Sir,
Any bleeding test have you done?
sir,
What is the test you do for thrombocytopenia? Bleeding time. Bleeding time, not clotting time.
Bleeding time.
Bleeding time. That is asking other tests done or not.
Then you would do take.
Tech can be done, but routinely we don't do. No? Any other test, PTNR, APTT is done.
PTNR APTT was done, sir. It was no.
Normal. It is normal. So you have to rule out other conditions like chronic liver disease. You can have thrombocytopenia, but you can have elevated PTNR. Patient on heparin. Patient can have thrombocytopenia, heparin-induced thrombocytopenia. Patient can have which elevation? APTT elevation. So you have to rule out other causes. What is the definition of ITP? There is no actual definition. It is after ruling out all other causes, diagnosis of exclusion. You rule out all other causes, then you don't have any other choice, then it is ITP. That's why we have to rule out so many conditions to make a diagnosis of ITP. You have to rule out SLE, dsDNA, ANA. You have to rule out conditions like antiphospholipid syndrome, HIV, like infectious mononucleosis. So many diseases has to be ruled out before telling that it is ITP. We don't have any antibody test for that. Actually, it is due to antibody, but we don't have any investigation for that.
We have sent viral markers for ruling out any viral infections.
Which viral infection?
Hepatitis, HIV.
There is HIV and dengue.
Dengue.
That is common in our country.
Lepto was done.
Okay.
And malaria was done, sir.
Okay.
This came out to be negative.
Okay.
Then following which
So you have now a patient who is not having any other disease, but only thrombocytopenia.
thrombocytopenia.
Possibly we make a diagnosis of ITP. Now how do you proceed? This patient count is only 4,000 according to you, and she is having bleeding. What do you do?
As there is bleeding manifestations, we can start on platelet transfusion.
How much platelet you give?
We can either give 4 pint RDP or 1 pint SDP.
What type of calculation is this? 4 type RDP, 1 type of 1 pint SDP. Which one you tell only one? I'll prefer only one. What is that?
SDP.
SDP. Why SDP? Single donor platelet. Why it is like that?
Sir, if
Suppose it is a dengue patient, dengue fever with thrombocytopenia. What you told is correct. You can give random donor platelet. But this is ITP. Here we prefer only single donor. Even if it is costly, we prefer only single donor. Why it is like that?
it's because SDP platelet the HLA matching will be done, so there will be no reaction will not be occurring.
Because ITP basically the baseline problem is immune related. So if you are giving multiple pooled samples, again the chance for autoimmune reaction is even more.
So this patient require lifelong multiple transfusions. Okay, and she has got a problem that antibodies are produced against platelet. So if you are taking multiple donors, there will be multiple types of antibodies produced against different types of platelets. So next time if you are transfusing the same type of platelet, the destruction will be faster than what you anticipate. That's why if possible, give transfusion, avoid transfusion. If required, you transfuse the patient with single donor platelet. Okay. So how much it was increased after platelet transfusion?
After 1 pint SDP was transfused later, her count were 2000.
Again it has come down. Okay.
and later on we again transfused her with one more STP, sir.
So then what happened?
The patient count began to increase. Next day counts.
Normally in dengue fever you might have seen, you transfuse 1 pint, it will increase to nearly 10,000. Each bag will increase up to 10,000. Why here it is not increasing?
It's immune related
It's
reaction.
immune mediated. Immediately it will be destroyed. Whatever you transfuse, it will be destroyed. So what do you do now? What is the ideal treatment?
You have to give either steroids or
You have to give pulse dose of steroid, rituximab, or you take the patient for IVIG
Maybe.
or plasmapheresis. Whichever is possible in our center, that has to be done. So whatever transfusion you give, this is becoming a useless thing because STP costs around 10,000 rupees, and you are giving transfusion without any effect. So what do you do now?
We have started here with the steroid also, sir. And
What is the dose of steroid?
we can give either prednisolone or dexa. Prednisolone 1 mg per kg dosage for we can give it for 4 to 6 weeks.
Okay.
Dexa we can give it 40 mg daily for 3 days. Then we can also start her on monoclonal antibody therapy.
What is the first line treatment in severe ITP? This IVIG.
IVIG.
IVIG is the first line treatment.
give 1 gram per kilogram.
That is the treatment. Then you can try pulse dose of steroid. What you told is either methylprednisolone 1 gram or dexamethasone 40 milligram. That can be given.
Then plasmapheresis.
What
Azathioprine
is rituximab?
monoclonal antibody, sir.
Against? It is against CD20. Okay, so that can be given. What is the difference between steroid and these monoclonal antibodies?
Act against only
It acts against only one monoclonal antibody, means act against only one target. Whereas steroid act against so many targets. So you have general immune deficiency. So before that, before giving all these things, you have to do some basic investigation. What is that basic investigation? You at least take an X-ray and rule out tuberculosis. Okay. Ideally, you have to take a CT scan and rule out. But in our country, you just take an X-ray and rule out at least tuberculosis, because all these things are immune related drugs. Then what do you do?
Then we can also give
So you have started steroid? Have you started?
started.
What
Yes,
happened to platelets then?
platelet counts began to increase.
Okay.
Next counts came up to be 10,000.
Okay. So now again you want to transfuse platelets?
No, sir.
Okay. Once it is bleeding tendency stopped, immediately you have to stop transfusion in ITP. That is very important, because if you are giving more and more transfusion, later patient will have more and more destruction. So we have to be very careful. If possible, stop the transfusion. Then
Later on, we have stopped the transfusion, and patient is improving.
so in a year, what are the targets of platelets? You have different types of procedures. You have to do LP, you have to do central line, you have to do neurosurgical procedures, you have to do abdominal procedures, minor procedure like central line artery. What are the targets?
Less than greater than 10,000 we can do LP can be down. 10,000 to 20,000 central line can be done, and less than 50,000 we can do minor surgeries.
Okay.
And up 80,000 to 1 lakh we can do major surgeries.
Procedures. Okay. Most important problem is neurosurgical procedure. They can have bleeding. So in emergency you have to do the procedure, but you try to increase the platelet count above 1 lakh. Okay. What happened to the patient afterwards?
Patient was improving and later on was discharged.
Okay. With discharge with?
Discharged with
What is the drug? Normally they continue, hematologist?
Steroids.
Steroids and?
Azathioprine.
Azathioprine.
Okay. What are thrombopoietins or thrombopoietin production
agonist.
agonist?
L-thrombophobin.
One more drug?
Romiplastin.
Okay. When will you start L-thrombopag?
If the other drugs are not
Not responding to the steroids.
Okay. What is the action of this drug?
It is actually erythropoietin
Okay. It acts only in the bone marrow. It increases the production. Okay. But here the problem is increasing destruction. Even if you start this drug, nothing will happen to the patient, because whatever is produced, it will be destroyed next day. It will be destroyed. So unless until you start steroids or any other immunomodulators, you cannot give L-Thrombopac, even if, because these drugs are very costly. And if you are giving L-Thrombopac, simultaneously you have to give steroids. Otherwise, there will not be any response. What are the indications for L-Thrombopac other than ITP? One more indication you can tell.
Chemo induced.
Chemo-induced it is not recommended. It can be given off-label use. It is indicated in only one condition, that is hepatitis C induced thrombocytopenia. But ITP also now it is added, that indications are added. Other conditions like dengue and all, we don't give, no. Because dengue also actually it's a immune mediated destruction. You don't give it routine because it is not indicated. Anything else, sir? LPN.
Thrombotic thrombocytic.
TTP.
The roll up platelet transfusion.
Sir,
Is there a role or not? No role.
What will happen?
Except in like acute emergency, you have to avoid platelet transfusion.
So it will further thrombosis may be, and then it may lead to embolic phenomena.
So I will remove plasmapheresis or
What is the mutation in that TTP? Adam 13. So it like sir told, it will aggravate the problem. So we try to avoid it. Anything else you want to add?
So in patient coming with ITP, actually we can divide the symptoms into critical bleeding, severe bleeding, and minor bleeding. So treatment plan will be according to that presenting symptoms. So critical bleeding means patient is hemodynamically unstable with some respiratory or circulatory compromise, along with bleeding into the intracranium or intra-abdominal, or maybe like retroperitoneal bleeding or even pericardial bleeding. In those conditions, we have to give platelets. But in all other conditions, we try to avoid platelet transfusion. The ITP is a condition actually we try to aggressively manage even if the counts are less than 20,000, but not with platelets but other supportive managements. So ideally the first treatment plan for ITP will be giving IVIG, which is actually 1 gram per kilogram can be given to maintain a platelet count above 50,000. But if it is not responding, we can start a second line drug that is actually IV steroids, which we can give either 40 milligram Dexa can be given OD for 3 to 4 days, or maybe we can give methotrexate 1 gram can be given about 3 to 4 days again. This is the main line of treatment. Along with that, if it is not very critical bleeding, we can always try second line managers like tranexamic acid or like L-Thrombopac or can be given. So these are the second line and the first line management. But a patient coming to ED with acute bleeding manifestations like intracranial hemorrhage or retroperitoneal bleed and all that, we have to emergency give this platelet. Again, the recommended treatment option will be a single donor platelet. So main thing is difference is we take a sample from a single donor and which we will titrate to multiple samples. We get about 4 to 6 packets of platelet. And usually we get in a normal patient we get a rise of about 50,000 platelet with the one SDP. But in ITP again the rise will be very less, but we can actually avoid the emergency situation. So again that same pack can be underwent through a leukocyte reduction or maybe an IR can be or radiation can be done before giving to the patient. So that is the option for giving platelet. But pooled or RDP is not usually recommended in ITP patients. And again, if a person who is having above 30,000 count with bleeding manifestations has to be shut on steroids, but in all other conditions above 30,000 is a safe count to be discharged. But even a newly treated patient with 30,000 counts with even mucosal bleed have to be admitted for further evaluation. So usually mucosal bleed is actually an indicator of like internal bleeding in case of ITP. So they requires admission for evaluation. But in all these conditions, the primary management will be like first will be IVIG, second steroids, and third will be alternative treatments. So only in emergency we go for platelet transfusion. And along with the initial management, we have to think about other causes of like other issues related to this. Like we said, any immune-mediated hemolytic anemia, or maybe like any other coagulation disorders, like any elevated INR, anything has to be we think about. So those things also need to be corrected along with the acute ITP management. So a lot of times these two can coexist and can complicate the conditions. Also related conditions along with like autoimmune previous history and also pregnancy related thrombocytopenia all have to be dealt accordingly along with the main primary treatment. So our primary aim in ER will be to evaluate the patient for classifying the patient into whether it is a critical bleeding, severe, or a minor bleeding. Depending on that, we can immediately arrange for platelets, and whenever possible, from the relatives itself, we can get a single donor platelet. And then the remaining management we can start from ED itself, like we can arrange for IVIG if possible, or we can give a pulse dose of steroid initially to. But the thing is actually IVIG will take at least 1 day to improve the count, and steroids will take at least 2 to 3 days minimum to get the improvement in count. So this kind of patients, only if they can wait, only we start for this kind of treatments. So this patient, we could have even tried for steroids in the initial stage because her bleeding was not critical as such, but platelet actually initially given was not much, shouldn't show much improvement, but after she improved with steroid management.
How do you differentiate purpura of thrombocytopenia from purpura of vasculitis?
Blanching test.
Blanching and?
I think this is light.
One is blanching.
Blanching.
Other one is palpability.
Palpable.
If purpuras are palpable, then it is vasculitic purpura. They are non-palpable, then it is due to something else, including thrombocytopenic purpura. Okay. Is there anything else? Thank you.